talk is about labor and delivery complications. It's going to come from a maternal perspective. Specifically going to go over things like preterm labor, rupture of membranes and related problems with that, malpresentation, as well as problems with position. So as usual, it's just a educational video for thinking about. It's not for managing patients or for treating yourself, and make sure if you have any sort of problem that you see a qualified medical professional. All right, so rupture of membranes. So initially you have to make this diagnosis, right? And so you're going to hear a story of loss of fluid. There might be blood in the fluid, and then you have to confirm that there actually was a rupture of membranes. And so the way you do this is there's a few initial tests and then some more sort of detailed tests you can do. So initially you do a speculum exam, look, see if there's pooling of fluid, do a nitrazine test. Nitrazine test is essentially like a litmus test. So if the pH is high, it should turn blue. So it's above 7 would be an indication that you have rupture of membranes. So the amniotic fluid is more basic than the normal vaginal fluid. So it's nitrazine test, looking at pH. pH will be elevated in a positive situation when you have ruptured membranes. In the Fern test, you see a sort of ferning type crystallization pattern that amniotic fluid can make. Then there's another test called an Amnisure test. And an Amnisure test uses immunohistochemistry. So looking for antigens using monoclonal antibodies to make the diagnosis as well. So if you're unclear after this initial testing, then you can go on and do more testing. And so one thing you can do is do an ultrasound to look for amniotic fluid. So if you have oligohydramnios or a decrease in amniotic fluid from previous, you might be thinking, okay, maybe that there has been rupture of membranes. You can also do something called a tampon dye test. And so the way that works is you do amniocentesis and you put dye into the amniotic fluid and see if it leaks out. So if it turns the tampon the color of the dye, then you know that you've had rupture of membranes because you have fluid going from the amniotic, or you have the dye going from the amniotic fluid down through into where the tampon is. All right, it's important to make sure that you get this diagnosis right because it can have big implications. I remember seeing a patient who was mercy flighted on a helicopter to the hospital because of the diagnosis of ruptured membranes made at an outside institution, and and it's because she had a lot of really serious comorbid conditions and was going to need a really high level of care when the delivery was going on. And it turns out that she hadn't had rupture of membranes and she was essentially fine and could go home, and she had undergone this big helicopter flight, and all the problem was created by misreading a test. And so she had sex earlier in the day with her husband before a test for rupture of membranes was done, and that test, having sex made the test be a false positive, and it would set up this huge chain of events. So it's important to confirm this diagnosis and be pretty sure about it. And so when is it normal to have rupture of membranes? So the normal time is full term after the onset of labor. So if you're anything besides that, besides being full term and besides after labor is started, is abnormal. And we'll go over the different types and terminology about that in later slides. So the physiologic importance of ruptured membranes is you have the membranes rupture, some fluid leaks out, and then the fetal head moves down, it engages with the uterus, puts pressure on it. This mechanical pressure can cause prostaglandin release, can help the cervix mature by breaking disulfide bonds around there and help the labor and delivery proceed. All right, and so an important thing to think about when you have ruptured membranes is to make sure that the cord's not prolapsed. You have this, as you can imagine, I think you have the uterus here, and so the fetus is there inside, and then all of a sudden there's going to be things moving around when the fluid starts leaking out. The head will go down and ideally sort of plug the hole, and the cord could prolapse out or get trapped. And I think it's kind of easy to think how when this happens, all this sudden movement will occur, and the cord could prolapse, and the fetus could cut off its supply by blocking off the umbilical cord. Okay, so this is an aside a little bit, but I wanted to go over sort of what the chorion, what the amnion are, and I think the way to do this is, and that's what's rupturing, right? The rupture of membranes. The amniotic sac is rupturing. So I want to go over so we understand really what these things are. And then the other context that this comes up, and it can be important for understanding, is having to do with twinning. All right. So we'll start out with just the normal process. So you have an egg, and you have fertilization, and then that egg is now called a zygote. Fertilized egg is a zygote, and it's going to be increasing in numbers. It starts out as one cell. The egg is just one cell, and it's going to divide up by a process called cleavage into without growing, just dividing into a lot more cells like this, and that's the initial sort of process that takes place after fertilization. Then after that occurs a number of times. Once you get to the 32 cell stage, you're called a morula. All right, M-O-R-U-L-A. So now you're a morula. And then you go on to become a blastocyst or blastomere with further division. And so the difference in the morula and the blastomere is that now you have an outer outer layer of cells called a trophoblast, and you have an inner cell mass. All right, so this is just the normal stages that happen. So you have fertilization. Now you call this a zygote. You have divisions by cleavage. You become a morula when you get to 32 cells. Then you develop an outer trophoblast with a cavitation on the inside and an inner cell mass. And now you're a blastocyst, which will then implant. Okay, and so where the chorion and the amnion come into play here is, so the amnion is the membrane covering this inner cell mass, and the chorion is what develops from this outer trophoblast. Right, the trophoblast becomes the cytotrophoblast and syncytotrophoblast, which makes up the chorion. It makes the fetal contribution of the placenta. You have the chorionic villi grow out of it to help bring in, facilitate the exchange of gas and nutrients. So that's the amnion and the chorion. All right, so you have the reason that this is important for twinning is because it kind of helps explain what's going on when you're thinking about, well, are we diamnionic or monoamnionic or dichorionic, monochorionic, or whatever. So with dizygotic twinning, this is the easiest one to remember because it's just essentially you're just like siblings, but you happen to be in the uterus at the same time together. So you have two eggs, right? They both get fertilized, they both become regular morulas, they both become blastocysts, and they both implant somewhere in the uterus. And so I think it's pretty clear to see that you're going to be diamnionic and dichorionic, right? You have two trophoblasts which will develop, and you have the amnion covering the inner cell mass, and so you have two of everything. Now you get into monozygotic twinning, which is where it becomes a little bit more interesting. So you have the egg here, fertilization, zygote formation, and then so depending on what happens with the morula, so if the cells sort of divide up here in the morula, and you have two different poles, you can see that you're going to have one covering of these cells, right? And then you can have another covering of these cells, and then you'll have the two different chorions, right? So if you split really early on, you've sort of divided in the very earliest morula type stage, then you divide up and you have two different amnions, right? Two different coverings of the earliest cells, and then two different chorions. So it's diamnionic and dichorionic with a monozygotic twin, which is also the same situation that you had here, the dizygotic twin, which I think almost makes sense intuitively. If you split up so early, it's almost like you had two eggs to start out with, like in the case of dizygotic twinning. So this happens before 4 days, and it's about 8%. Right? By far the most common is the dizygotic. All right, so let's say that the splitting doesn't happen quite that early, and you get to this regular sort of morula. All right, and then so if you're a regular morula, and then you turn into the blastocyst, and then divide up into the two different cell masses, you'll have each inner cell mass will have its own amnion, but by this time you're all enclosed within one trophoblast, and so you have one chorion. So you're diamnionic and monochorionic at that point. If the division comes at the latest, which is the 8 to 12 days, very extremely rare, then you're monochorionic and monoamnionic. All right, so that's the tie-in between what the chorion and the amnion are and how it relates, how that can relate to twinning. All right, and so another thing actually I wanted to mention is that, so you have the chorion, which is the outer cells that come from the trophoblast, and then you have the inner layer, the amnion, that's right on top of the inner cell mass. All right, so with time and the production of amniotic fluid, the amnion gets pushed out and fuses with the chorion at around 14 weeks. Okay, so it starts out right on top of the inner cell mass. You start making essentially urine, which is like the amniotic fluid the fetus does. It pushes the amnion out and fuses with the chorion, and that happens around 14 weeks. That's why you might recall earlier on the amniocentesis. Usually don't do that before 15 weeks because you want the chorion and the amnion to have fused before you do that procedure. All right, so definitions of abnormal. Okay, so we said the normally ruptured membranes is after labor is started when you're full term. So if you're not full term, then you have preterm rupture of membranes. Okay, so that's anything less than 37 weeks. You can also have premature rupture of membranes, PPROM. PROM right here, premature rupture of membranes. So that you have rupture of membranes before the onset of labor. Notice it's not saying in relationship to weeks there. All right, and if you want it combined, preterm and premature, you get PPROM, preterm premature rupture of membranes. So that's you have rupture of membranes both before 37 weeks and before the onset of labor. All right. And then you can have prolonged rupture of membranes. And again, that doesn't doesn't talk about time. It's just saying that from the time of rupture of membranes to delivery, it's been more than 18 hours. So it's not saying a certain weeks of gestational age. Okay, and then we get to management of these things. And so the main thing with management is you pick a time over which before the time you pick and after, the concerns are different. All right, so I'm going to pick 34 weeks, and some people might use 36 weeks, some people might use 32, but 34 I think is a pretty reasonable way to think about it. And so before this time, you're worried about the fetus, you're worried about fetal maturity. Okay, and after this time, you're more worried about infection. Specifically, you're worried about chorioamnionitis. So after 32 weeks, you're very concerned about infection. And so what you do is going to depend on where you are along this continuum. So if you're greater than 34 weeks and you have rupture of membranes, labor starts soon after, and then you have delivery, that's okay. You're gonna sort of go with that. If you're over 34 weeks and you have rupture of membranes, it becomes prolonged rupture of membranes. You've gone on for greater than 18 hours after rupture of membranes. You haven't delivered, or you don't know the GBS status, and you're going to want to give antibiotics to prevent infection. You could also think about inducing or augmenting labor. Okay, so once you get past the time where you're not so concerned about fetal maturity, but you're more concerned about infection, then that's when you want to move on to helping the delivery happen and prevent the infection. So antibiotics, possibly, and augmenting or inducing labor. If you're before 34 weeks, then you're more concerned about fetal maturity. Okay, so if you have PPROM, so preterm premature rupture of membranes, there's no labor going on yet. So what you can do is you can give antibiotics, you give ampicillin, erythromycin, and that what that does is that increases the time between when you have rupture of membranes and when you have labor onset. Okay, and then you can also give steroids to help the lungs mature. If you're in labor, then you can consider doing tocolytic therapy, which we'll talk about specifics of that later, and giving steroids. All right, so tocolysis is to stop, to slow down or halt labor temporarily for a day or two to allow steroids to work, to allow fetal lung maturity, and then you have delivery, which is different than the antibiotics. So you give the antibiotics because one of the main etiologies of this of PPROM is an ascending infection, so you give antibiotics, and that's been shown to increase the time from the onset of rupture of membranes to the start of labor. All right, so that's the general ideas behind that. Now we'll move on to preterm labor and delivery. So we're talking about this is again less than 37 weeks. There's a lot of risks associated with this. There's not a clear etiology, but in general, I think I would associate infection with preterm rupture of membranes and preterm labor and delivery. There's also preeclampsia, chorioamnionitis, other infections. Okay, so if you're before 37 weeks and you have this, then there's two main things that you think about. So one is gestational age, and the other is birth weight. So they're going to have the biggest impacts on the outcome. The way you can describe a gestational age and a birth weight that aren't congruent with each other is using these terms here. So intrauterine growth restriction and small for gestational age. So you could say that that's the situation where you have a gestational age and a birth weight that's lower than you'd expect for that gestational age. So intrauterine growth restriction is a cause of small for gestational age baby. And low birth weight, this doesn't necessarily have to have anything to do with intrauterine growth restriction, but it's just a sort of an absolute number, and if you're less than 2.5 kilograms, you're low birth weight, and that could be what you'd expect given the gestational age if you have a very preterm delivery. Right, in broad strokes, mortality is heavily influenced by gestational age, so the lower limit of viability is around 24 weeks. That's where you're at about a coin flip, so a 50% chance of viability. When you get up to about 34 weeks, you get to near normal survival, near normal mortality, and then after 37 weeks, you're not preterm anymore. And right in that 34 is that number that I used before when you're talking about switching from the risk of thinking about fetal maturity to infection is around 34 weeks. Because around 34 weeks, the mortality from delivering early at that stage isn't all that greater than it would be if you were full term. The main concerns are with a preterm delivery are respiratory distress syndrome. The fetal lungs are immature. That's also called hyaline membrane disease. And the other big one is necrotizing enterocolitis. There's other concerns that happen, lots of them with preterm, and another big one would be sepsis and also intraventricular hemorrhage. Okay, continue on to some of the therapies that you'd use for preterm labor and delivery. We briefly mentioned this before. And so the broad stroke is that you use tocolysis to delay delivery. So you want delayed delivery by a day or two using betamethasone, or to allow the betamethasone that you give, the steroid that you give to help the lungs mature. And you have to balance this against risks or contraindications, reasons that you wouldn't want to hold up the delivery. All right. So can you think of anything that you'd say, okay, we're not going to use tocolysis, even though the fetus might benefit from the steroids and the lung maturity? Anything that would say, well, we can't wait for those 2 days to allow that to happen. Right, things like placental abruption, got a lot of bleeding going on with that, non-reassuring fetal tracings, things like that would say, okay, really bad preeclampsia would say we can't delay this by 2 days, we have to just deliver now. There's a lot of agents that are used for tocolysis. Those are called tocolytic agents. So in general, you just pick a tocolytic agent, you try that, see if it reduces the strength and number of contractions, and then if it doesn't work, you can stop that one and try a different one. Between 24 and 32 weeks, start with indomethacin or a calcium channel blocker. So indomethacin is, the way to think about that, is an anti-prostaglandin. Right? So indomethacin inhibits cyclooxygenase. Cyclooxygenase is an important enzyme for making prostaglandins. I think this is fairly intuitive to think about because you give prostaglandins to start or to induce labor. So you can give indomethacin to stop that and potentially slow down or inhibit labor for a couple of days. The two main side effects, I think, are also fairly intuitive. So you're giving indomethacin, that's like an NSAID, it blocks cyclooxygenase. So what are some things that can happen with that? Well, you can have renal damage, right? And not just in OB, but just in general. Adults, taking lots of NSAIDs can have renal damage. So if you have renal damage in a fetus, what would you look for? You do an ultrasound, you look for oligohydramnios, not producing the amniotic fluid. So the other thing that indomethacin or NSAIDs can do is the ductus arteriosus is supposed to be patent now. Just physiologically, that's the normal situation. It's supposed to be patent, and it's kept patent by prostaglandins. So if you give indomethacin and reduce the prostaglandins, then that duct could close prematurely, which is another side effect, and a nice normal anatomy tie-in. Another note here is that you can give magnesium sulfate as a general neuroprotective agent for a fetus that might be delivered early. It's been shown to help, so that's something that can be given. And once you get to 32 to 37 weeks, you continue to use calcium channel blockers, nifedipine, based on the general idea that they reduce the calcium available for muscle contraction. And you can also use beta mimetics, that's beta agonist type drugs. And some names to know about are terbutaline, so that's the one I listed here, and then there's another beta agonist called ritodrine. It's not used in the U.S. at least, but might be used in other places now. And terbutaline's used, has a black box warning because a lot of serious cardiovascular side effects, but it's used as long as it's not used for more than 48 hours. So some other ones, magnesium sulfate is believed to have its own tocolytic type effects by itself with decreasing calcium availability, membrane stabilization, It's not as effective as the others. Oxytocin antagonists, I think if those are the most physiologically intuitive, right? Oxytocin is the main hormone that stimulates all of this. So you want to antagonize that. So that's another medication that can be used. And then hydration, and that's a nice physiology tie-in. So you have the posterior pituitary hormones, which are ADH and oxytocin. So let's say if someone's really dehydrated, well, their ADH level would be very high, right? They're trying to resorb as much water as they can. They want those aquaporins to be put in by ADH to resorb the water. So they have really high ADH. And these are both the posterior pituitary hormones. Unfortunately, they're structurally very similar, and they sort of thought to cross-react at the receptors. So if you have a high ADH, maybe that's acting at oxytocin receptors and is sort of stimulating labor a little bit. And I don't think that, I mean, you wouldn't go to hydration if you're really serious about tocilizing someone, stopping labor for 2 days. You wouldn't use hydration as your mainstay of treatment, but it's just a nice physiology tie-in, and it's something that is used a little bit. But these are the go-tos. Indomethacin or nifedipine calcium channel blockers for the early, 24 to 32 weeks. Later on, 32 to 37 weeks, calcium channel blockers, and also beta-mimetic agents. And then when you're doing this, you want to be thinking about fetal lung maturity, giving steroids, and generally less than 32 to 34 weeks, you'd probably want to try to get a day or two of steroids if it's safe to do so before delivery. All right, so now moving on to a little bit of a different topic from the ruptured membranes and preterm labor topic, and this is malpresentation in position. So this gets into the issue of cephalopelvic disproportion a little bit. So if you have, if you just think about the anatomy here, you have pubic symphysis and the sacrum down here, and so tip of the sacrum up to the pubic symphysis, that's the AP diameter that you're concerned about for delivery. So the orientation of the fetal head coming down here is going to have a lot to do with if you have problems with cephalopelvic disproportion or not. All right. So breech presentation. Remember, presentation is what part is facing what part's going to be delivered. And there's subtypes of breech. So footling, a foot sticking out. Complete, which is like should be another, is like sitting Indian style. And frank, you have the hips flexed and the knees extended, so the feet are way up by the head. I don't really see the utility of learning the different types of breech presentations, but it's important to know that when you have breech presentation, how you diagnose this. You're going to diagnose it by Leopold's maneuvers, that's palpating around the uterus and feeling where the head is and where the butt is. You also can diagnose it by ultrasound, and then the management of it's good to know. So before 37 weeks, you really don't do very much because there's lots of flipping around and moving around without any intervention. So this problem might resolve itself, or you might go in and correct it, and then it might just switch back. So you don't really do anything before that. But after that, then you can try to sort of manually flip from breech to cephalic presentation. And so you can try that. If that doesn't work initially, or if it does work, if you can't get out of, if it does work, you get out of breech, but then you switch back, then you can try again. You can use epidural analgesia if that is thought to help. But ultimately, if you can't get out of breech, then you have to do elective cesarean section. I don't really think that at least I never saw trial vaginal deliveries that are breech. Although I mean, I think it's something that might be done a little bit. So I would ask around and see if that's something that's actually done. I'm not familiar with that being done. All right, so the other presentations just to mention are shoulder, and sort of versus the other, because shoulder is an indication for cesarean section. The other is brow, face, and compound. So compound is when you have an arm sticking out. Or if you have a foot sticking out, that's also could be considered a compound presentation, but then we would go more into the footling breech category. But so the brow, face, and compound with an arm sticking out, cord prolapse is associated with the compound presentation. Those three you can trial vaginal delivery, so you can do vaginal delivery there, and it might work. It might be a little bit harder, or it might not be successful, but at least you can try to go that route, as opposed to shoulder. That's an indication for cesarean section because it's associated with things like uterine rupture, cord prolapse, and other very serious complications, and you're not going to be able to do vaginal delivery, so you have to do cesarean section there. So now moving on to from presentation to position. So when you're cephalic and you're vertex, then you have the head facing you, and then you have the normal setup here is OA, right? So that's occiput anterior. So we'll just draw. How do you know that it's the occiput? Remember, you're filling the fontanelles here. So you see this little triangular, which is going to be the posterior fontanelle, and that's going to be anterior. So that'll be the up here by the pubic symphysis, and you'll have this larger, more diamond-shaped fontanelle, which is the anterior fontanelle. That'll be down here by the coccyx. Right, the tip of the sacrum, and up here by the pubic symphysis, you have the occiput. Actually, the occiput anterior. That's the normal setup, and then we know that the position can be different than that. And actually, initially, the way you start out is you start out in this transverse position. All right, so we'll keep the pubic symphysis here, and the sacrum here. And you start out with the fontanelles oriented like this, so you're transverse. Then one of the cardinal movements that you have, remember from earlier, from the normal sort of labor setup, is you go from transverse, so that would be denoted as OT, and it could be ROT or left OT, depending if it's right or left. But you start out transverse, and then you flip into typically occiput anterior, because OT doesn't really deliver. Babies aren't delivered occiput anterior. They're usually delivered. I mean, they're not delivered OT. They're not delivered occiput transverse. They're either delivered occiput anterior, which is the normal, most common, or occasionally occiput posterior. All right. So the general management, if you have something abnormal, and so we know what's abnormal now, right? Occiput posterior, that's abnormal, and occiput transverse, those are both abnormal. So if you have something abnormal, generally what you do is that once you've gotten once the cervix is fully dilated, you're moving into the second stage of labor. If possible, you're going to try to rotate. You can use forceps or do this manually, and you want to try to get out of these positions into the occiput anterior position. And if that fails, then you can try, if the station allows. So if your station allows, meaning if it's at least +1 or more commonly +2, then you can try an operative vaginal delivery. Right, so that's using the forceps, that's using vacuum suction to try to assist the delivery. And then if the labor's arrested and you can't do an operative vaginal delivery, and you're unsuccessful at rotating into the normal position, then you move on to cesarean section. All right, so that's how you manage position. And remember that OP and OT are abnormal. They're associated with increased chance of having labor arrest or prolongation or arrest disorder of labor. All right, so the management. First step, try to rotate it back to normal. If possible, do an operative vaginal delivery. For example, if you're OP +2, try vaginal delivery, and if that is unable to work, then you move on to cesarean section. All right, so that's the end of the talk. Thanks for watching. Visit the website for more, and consider checking out 52kids.org and making a donation. Thanks for watching.